It's a pleasure for me now to welcome Gabor Mate to the stage. Many of you will have known his work. He's written on everything from addiction to mind and body wellness. Rather than going for the quick fix, Dr. Mate usually invites us to think big and to think about the complexity of each and every one of our lives and making meaning from research, case histories, and offering our own experiences and insights. And we're about to hear him speak to science and compassion in understanding our differences. Please welcome Gabor Mate.
So just to get to my own feelings, as I was listening to Brooke, I certainly have witnessed everything she described, the lack of empathy, the utter blindness to the person's actual experience, the evident lack of compassion. And I've seen this in emergency wards in Vancouver. I've seen it in psychiatric wards. I've seen it throughout the hospitals. I say evident lack of compassion because it's not true that there's a lack of compassion. Everybody's actually trying to do their best. The nurses, the physicians, counselors who dealt with Jeremy, I'm sure within the limitations of their own perspective, were actually trying to do their best. But that still leaves me with a frustration because the key word here is the limitations of their perspective. The problem is not lack of compassion or lack of goodwill or good intention. The problem is that the system in which we're trained, in which we operate, entirely lacks perspective about what's really going on. If you look at something like the current overdose epidemic, where in the United States, every 3 weeks, they have the equivalent of a 9/11. Every 3 weeks, a 9/11 happens in the US in relationship to the number of people dying. And yet, where's the public outcry? Where's the dedication of resources and public energy that the one unitary 9/11 provoked in the States? And similarly in Canada, the numbers of people are dying or increasing. And the solutions have been evident for decades. For decades, we've talked about harm reduction. For decades, we've talked about supervised injection sites. And yet, until very recently, the government of Canada fought the one injection site that existed. And now governments are scrambling to open them because finally, as a result of human sacrifices that were sacrifices not just to addiction, but also to our social and systemic ignorance and willful ignorance about what needs to be done, these people have had to lose their lives. And Jeremy's loss of life wasn't simply due to heroin. It was also due to a system that never got his experience, where the experience of a counselor who actually was empathetic and wasn't judgmental had to be a especially unique experience, but it did not characterize the man's or the family's trajectory through the healthcare system. Well, why is it that compassion and understanding have to be a unique experience? Why isn't it that that's just what the system delivers, that we all deliver automatically and smoothly and as a matter of course? It's not because we don't try our best. It's not because we're not wanting to help. But if we are wanting to help, and if we're trying to do our best, then what is lacking? Then clearly what is lacking is perspective. And so this is called a provocation, and I tell you, I'm personally provoked by having only half an hour to talk to you, because this is the kind of material that I would deliver over 2 days in depth. And so all I can really do is provoke your curiosity. All I can really do is provoke your interest and perhaps provoke you to recognize that what you've understood to be the case might not be the case, so that you'd be willing to look at it more deeply. Now, what is the source of that disconnect? Well, given that people are trying to do their best, and yet people are dying who don't have to die, what is the source of the disconnect? What is the source of the apparent lack of empathy? The source of it, I think, resides in something that an author, an Auschwitz survivor, Primo Levi, wrote in one of his amazing books on the genocide that he experienced. He said, "Our difficulty or inability to perceive the experiences of others is all the more pronounced the more distant those experiences are from ours in time, space, or quality. We can be moved by the tragedy of mass starvation on a far continent. After all, we have all known physical hunger, if only temporarily. But it takes a greater effort of emotional imagination to empathize with the addict." I'm saying this myself. Because we think that the experience of the addict is so far removed from ours. Well, let me see if that's really true or not, or whether it's just an actual fact of denial. So let me give you a definition of addiction. Addiction is a complex process, but it's manifested in any behavior that a person finds temporary pleasure or relief in, and therefore craves, but cannot give up despite negative consequences. So the essence of addiction is craving, pleasure, relief in the short term, negative consequences in the long term, and inability to give it up despite the negative consequences. Now notice that I said nothing about drugs. These behaviors could have to do with drugs, and saliently they do, but they could also be sex, gambling, TV watching, internet, pornography, eating, shopping, work, video games, gambling, of course. There's a casino just around the corner here. And so let me ask you to consider now, from that perspective, from that definition, how many of you would acknowledge that at one time or another in your life you had an addiction to anything? I don't care what. Just raise your hands. Okay, you got the vast majority here. Now let me ask you the next question. I'm not going to ask you what you were addicted to or when or for how long, but I'm going to ask you to consider, what did you get from it? What did it do for you temporarily that you wanted or craved? And if you are willing to say so, again, nobody's going to ask you about what or when or how long, but just what was the benefit, the so-called benefit that you got from it? For a moment, okay? So your hand is out at the back there. You have to shout out because I have trouble hearing. What? Go ahead. Pleasure. Okay, thank you. Yeah? Numbing. Okay. Numbing, thank you. But take one more. Anybody? Yeah? Comfort. All right, let's just look at those three things. Pleasure is something we all want. In fact, it's necessary for life. It's necessary for life. The real question is, given God's green earth and everything in it, why did you lack pleasure in your life? Numbing. When do people have to be numbed? So when you go to the dentist. So when you're going to have pain. So it's a response to pain. And comfort, again, is something that's a totally normal human aspiration. The problem is that you were in so much discomfort that you didn't know what to do with it. And so that we see that the addiction is not a choice that you made, nor is it a disease that you inherited. It was an attempt to solve a problem. The problem of pain, so you had to be numbed. The problem of lack of pleasure, of alienation, of boredom. The problem of discomfort. And if we want to understand why you lacked comfort, why you lacked pleasure, why you had pain, we have to look at your life. And these factors always goes back to childhood trauma in every single case. This is what we don't learn. We don't learn that human experience is shaped, or human functioning is shaped by human experience in the world. And so that the average nursing student does not hear the word trauma in 4 years of education. The average medical student, never mind that they don't get a single lecture in trauma, that they don't get a single course in it, they don't even hear the word trauma in 4 years of medical education. So that when Jeremy shows up at the counselor's office or the physician's office or the nursing station, nobody realizes that they're looking at a traumatized human being. They think they're just looking at an addict who's behaving in certain ways willfully and out of choice. Now, I just got an email this morning as I was sitting here at the table listening to Brooke talk. Yet another study talking about pain that shows that people with adverse childhood experiences are much more likely to have chronic pain as adults. Now, I could go into the physiology of that, it's very straightforward, but nobody teaches you that. So all you see is a drug seeker. You don't see a traumatized person whose physiology is responding to painful childhood experiences. And so what I'm saying is that the difficulty that we have is that we have trouble understanding people with different formative experiences than ours. And precisely because, if I look at something like addiction, as you could see from the show of hands here, it really is a matter of a spectrum, and we're just about all of us are on the spectrum. But precisely because we're all on the spectrum, and we think we could deal with this in our own life, we say, well, why couldn't they deal with it in their own life? We're full of judgment. Why couldn't they deal with it? If you've never been profoundly depressed, you don't have an idea what it's like to be depressed. You have no idea what it's like to have life be utterly drab and meaningless and threatening to the point that you might even want to leave life, to the point of trying to kill yourself. Because it is on a spectrum, and we've all felt down sometimes. We've all felt alienated sometimes, but we snapped out of it. And we have no idea what it's like to be deeply into it, where choice no longer exists. And so we have great difficulty understanding people whose brains give them a different experience of life. And I'll say something about the human brain in a moment. There's also something else that comes into it. There's a new word I learned recently called intersectionality. How many of you have heard the word? That's great. A few of you have. I haven't until 3 weeks ago, to tell you the truth. But here's what it means. We're all human beings. We all share that. We all share our species being as Homo sapiens. But then we start to have different experiences. Now, most of us in this room, as I look around, most of us, not all of us, but most of us are Caucasians in background. So that intersects. We have that in common. It's difficult for Caucasians living in this society to recognize that not being a Caucasian in this society gives you a completely different life experience. So if you're an Aboriginal native, and natives, of course, make up a disproportionate section of the care-receiving population, especially when it comes to mental illness and addiction, or when it comes to the criminal justice system. I mean, native Canadians make up, Aboriginal Canadians make up 4 or 5% of the population, but 25% or 30% of the jail population. The same with addiction. We have no idea what their experience is like. We think they're living in the same world because we live in a world. They think they live in we think they live in the same world. But let me tell you, they don't live in the same world. They do not live in the same world. There's a black American psychologist called Kenneth Hardy who talks about what he calls sociocultural trauma. And he talks about the experience of a black man walking down the street in the States is not the same as that of a white man walking down the street in the States. Now, the white man doesn't see that. He assumes that his experience is the universal experience. So what is that black guy so upset about? But he doesn't have the experience of not knowing when he might be beaten up by the police and what that does to his sense of self. And so we have trouble imagining the experience of others of a different race. We have trouble imagining the experience of somebody with a differently functioning brain. Now let me tell you something about the brain. We think the human brain is the same for everybody. No, it isn't. I'm going to quote you from an article that appeared in the journal of Pediatrics, which is the official journal of the American Academy of Pediatrics. The article is from Harvard University Center for Developing Child. And what is so frustrating is I travel around North America and the world talking about these matters. This evidence that I'm going to quote you has been published in major medical journals. The average physician never hears it. It's absolutely amazing how there's a screen, an ideological screen, that excludes reality from our perceptions. We keep talking about evidence-based practice, but we're not looking at some of the most important evidence. Now, let me ask you a question. Just be honest here. How many of you have heard about the adverse childhood experiences studies? Okay, the adverse childhood experiences studies. They're just the most important studies ever done from the point of view of your work. The most important studies ever done. And maybe 15–20% of you have heard about them. Now, that is not your personal failure. I'm talking about how the system excludes evidence that doesn't match its biases. The adverse childhood experiences, please look them up tonight. You can find them on the, it's been published in major medical journals. It's not like they're isolated somewhere in some weird journals. You can find them in major medical journals, major psychological journals. The CBC has had a whole series on it, on the program Ideas, and most people have never heard about them. That's miraculous. How come you've never heard about them? What is it that excludes this? What excludes this kind of information is that they don't meet the suppositions of the system. Now, the adverse childhood experience studies, the ACE studies, they looked at 18,000 adults in California. More than half of them had been to university, the majority Caucasians. An adverse childhood experience was physical, sexual, or emotional abuse, a parent dying, a parent being addicted, a parent being mentally ill, violence in the family, a parent being jailed, neglect, or a divorce. And for each of these adverse childhood experiences, the risk of addiction went up exponentially. They multiplied each other. By the time a male child had 6 of these, his risk of being addicted as a substance-using, injection-using adult was 4,600% greater than that of a male child with no such experiences. The risk of addiction goes up, the risk of mental illness goes up, of depression, of ADHD, of anxiety, of antisocial behavior, of relationship problems, of sexually transmitted disease, of autoimmune disease, and of cancer. And most of us have never heard of them. And these studies have been repeated in Alberta, in Finland, in other countries, always exactly with the same results. Now, to go back to the brain. And listen, I understand that, especially when I'm short of time, I tend to speak rather urgently with a fair bit of heat in my tone. I hope you don't feel assaulted. I'm simply very keen to get as much information and to provoke as deep a shift of perspective as I possibly can in a very short period of time. Anyway, here's what this Harvard article says about the brain. Now, did you know this? Well, let me tell you. These 2 paragraphs I'm going to read you now, they're not controversial. They are simply the summary of decades of brain research, and they're not taught in the medical schools or the nursing schools. The average healthcare practitioner never hears this stuff, not because it's not true, but because it threatens the reigning paradigm too much. So how's the brain constructed? The architecture of the brain is constructed through an ongoing process that begins before birth, continues into adulthood, and establishes either a sturdy or a fragile foundation for all the health, learning, and behavior that follow. I'm going to go through that paragraph again. The architecture of the brain is constructed through an ongoing process that begins before birth. What does that mean? That means that the kind of experiences that the pregnant woman has during gestation will already affect the brain of the infant. Which means that the infant who's gestated in a womb where the mother is stressed, abused, poor, discriminated against, is already going to have a brain disability because of the impact of the stress hormones on the developing brain of the child. And so consider that when you're looking at a human being and you think they're just like you, not necessarily, not necessarily, and the difference might have begun already when they're in the womb. And, you know, I could cite you 300 different studies showing the evidence for that. So this process begins before birth, continues into adulthood, and establishes either a sturdy or a fragile foundation for all the health, learning, and behavior that follow. They didn't say some of the health, learning, and behavior that follow. They said all the health, learning, and behavior that follow. Which means when you're looking at a human's behavior and you're judging it, consider what kind of experiences form the brain that drives that behavior. What kind of experiences? Look at the ACE studies that most of us have never heard about. And then they say the interaction of genes and experiences literally shapes the circuitry of the developing brain. That means that the kind of, if you look at addiction and which circuits are involved in addiction, or depression, or anxiety, or ADHD, or aggression, or anything else, you have certain specific, well-identified brain circuits, which I don't have the time to delineate for you right now, but the circuits of impulse regulation, for example, that stops you from acting out in a certain way, that they have to develop. If you look at addicts, the commonest brain scan finding is abnormality in the part of the brain that regulates impulses, so they can't help themselves from acting out their urges. But what shapes those circuits is early experience. Because which brain chemicals will be present in what quantities and which circuits will connect and which will not depends on the early experiences beginning in uterus. And to go on, so the interactions of genes and experiences, not genes by themselves, but the interactions of genes and experiences literally shapes the circuitry of the developing brain and is critically influenced by the mutual responsiveness of adult-child relationships, particularly in the early childhood years, which means that the key factor in shaping the proper development of the brain is the quality of the responsiveness of the adult world to the needs of the infant. That's what shapes the physiology of the brain. So when you have somebody who's not able to have pleasure, who's in so much discomfort that they don't know what to do with it, who's in so much pain that they have to numb themselves, or they lack impulse control so they act out, you're not looking at a bad person. You're looking at a person whose early experiences shape their brain in certain ways. That's what you're looking at. And any judgment or lack of empathy that you have doesn't come from your own, it comes from two sources, I suggest to you. It comes from, first of all, your lack of awareness of what that person is really experiencing. Because they're experiencing what you haven't. At least you haven't fully looked at it in yourself. And they're experiencing something that your education did nothing to prepare you for. Because you've been taught about behavior and behavior control, and you've been taught about symptom control, and you've been taught about pathology, but you have not been taught to understand the development of a human being in relationship to the environment and what is being manifested in their behaviors. And there's something else here too, which I think is more difficult to convey, but here's what I know. Having worked in the downtown east side for 12 years, it's not like what I'm telling you here was always available to me. I mean, I knew it intellectually, but that doesn't mean that my heart couldn't close down. It didn't mean that I couldn't be filled with judgment. It didn't mean that I couldn't act in ways that were hurtful to my clients. I certainly could, and I did sometimes. The part that we have difficult appreciating is how we create the other person. I know that on days when I was tense and judgmental, which usually had to do with factors in my own life that I wasn't dealing with, I had different clients. My clients were different. And then I'd say, why is everybody so ordinary today? What's wrong with them today? Not realizing that they're responding to me. And I'm telling you, you can change the other person like that, simply by how you show up. But for you to show up and to understand their own pain, to understand their pain and their experience, you have to do the kind of exercise that you were guided through by the chaplain before I spoke. You have to look at your own pain. You have to look at your own experience. And you have to develop compassion for yourself. So very often the compassion that we lack for other people is really a function of the compassion that we lack for ourselves. We just haven't worked it through yet. And let me tell you some bad news here. If you're working in the mental health field, you can tell yourself that I'm doing this because I want to help people, because it's a mission I have to support suffering humanity, and all that will be true. All that will be true. But also true, if my own experience is any guide whatsoever, is that you're also in this because on some level, whether you want to recognize it or not, you resonate with the people that you're working with. In other words, you've had your own trauma. And the question is whether you've recognized it or whether you've not recognized it. And if you haven't recognized it, you'll want to be fixing it in them. And you'll be very impatient when they don't get fixed that easily. And if you have worked it through in yourself, you'll have all kinds of compassion, all kinds of patience, and all kinds of understanding. And then, when you show up differently, I promise you, they will show up differently. Let me say a final word to you about trauma, which is a word that we use, but what do we mean by it? Everybody thinks that trauma means bad things happening to you. That's not what trauma is. Trauma is not what happens to you. Trauma is what happens inside you as a result of what happened to you. And trauma can show up in overt ways, like those adverse childhood experiences. And again, I urge you to go to the internet tonight and download the ACE questionnaire and fill it out on yourself. And when you see a client, fill it out on every single client you see. It's going to, like that, in 5 minutes, change your perspective on them, like that. But trauma isn't only those bad things that happen to people. Trauma is anything that constricts you, that limits you, that makes your responses more stereotypical and less flexible. Because you see, what happens with trauma is that it shapes not only the personality, it also shapes the brain. And we have this part of our brain called the midfrontal cortex, the MFC, whose job it is to regulate the body, to have insight and empathy and attuned communication with other people, and to regulate impulses, and to give us what is called response flexibility. Response flexibility means that when something happens, you have a range of responses that you can consciously choose. You're not just reacting. Now, very often, when we're dealing with challenging people, we're not actually response flexible. We're just reacting. And that reactivity on our part is actually means there's a limitation of our own midfrontal cortex because of our own traumatic experiences. So we want to develop here in ourselves and in our clients is a response flexibility, which means when person A does something, person B isn't just driven by their emotional reactions. Now the nurses that Brooke described at that orthopedic ward, I've seen it. There's no response flexibility there. It's all reactive. It's all reactive on their part because they're afraid. They're puzzled. They're bewildered. They don't know what to do. There's fear behind that rigid response. What we don't understand, this is what I'm going to leave you with, is the power imbalance between ourselves and our clients. You see, if I lost it with one of my clients, if they lost it with me, I'd have all kinds of recourse. I could call the cops on them. I could take away their methadone privileges. I could do anything I wanted to. If I lost it with them, which sometimes they did, they'd say, okay, I'm going to the college to complain about you. But good luck. Good luck being an injection using downtown East Side, homeless, junkie, complaining about a doctor to the College of Physicians. And each of us has this power that our clients do not. Now, we don't think of ourselves as powerful. We don't think of ourselves as wielding that kind of authority. But in relationship to their experience, we do. Which means that it's all the more important that we take responsibility for that power, that we deal with our own stuff, and we do our very best to transcend this limitation of not understanding the other person's experience. Thank you.